after that mind-blowing discussion on burning topics, we'll move on to the second session. That's on the complications of cirrhosis. I'll kindly call upon the chairpersons for the next session. Jayanti Venkatraman Madam, kindly clears the stage, please. Our own, very own Dr. Ashokananda Konar sir, you can grace the stage. Deepika Kedia Madam, thank you for joining us. And obviously Patrick Kamath sir, needs no introduction. Welcome to the stage, sir. Stage is yours, sir, for the session on complications of cirrhosis. There are 3 talks lined up.
It's very nice to chair a session with Professor Patrick Kamath. We have 3 important complications of cirrhosis to be discussed in this session, and we request Dr. Jasmohan Bajaj to take over the first session, and he'll be speaking to us on early detection and prevention of infection in cirrhotics.
Thank you. Thank you so much, and thank you, INASL, for this wonderful academic festival, actually. So this is an important talk. I'm not sure I'm going to be able to give it justice, but it actually raises some questions that we need to answer. So why do patients with cirrhosis develop infections? What are the issues with current diagnostic strategies? Basically, why is this talk necessary? Why do we need to diagnose patients quickly or even prevent this? What are the clinical clues that could indicate an infection? What special infections and populations are important? And what are the targetable foci, either now or in the future, that are important for this? So this is a conceptual model for pathogenesis of infections. There could be immune dysfunction, there is altered microbiota, and there are extraneous factors. So hint here, most of the things are related to extraneous factors, because immune dysfunction and altered microbiota, we can really not figure out in the end stage of patients with cirrhosis. So why does this happen? Remember, cirrhosis is an immune dysfunction disease. It's not just a disease of the liver. It affects immune dysfunction everywhere. This review that I wrote with Dr. Kamath and Dr. Reddy, along with things that Albios have clearly said, that there are changes in the gut microbiota, gut barrier dysfunction, but there are also changes in immune dysfunction, circulatory, gut-based, and in the reticuloendothelial system that allow microbiota and their products to actually translocate and cause end organ damage in the liver and elsewhere. So what are the current challenges? There are subtle clinical clues only. There are logistic barriers to completing the infectious workup. There's challenges with culture positivity, there's delays in turnaround time, there's a high prevalence of multi-drug resistant organisms, and there's presence of infections with organisms other than bacteria, such as fungi and viruses, for which we, alas, get to the patients too late. So this is the current flow that was from a nice review done in 2021 of bloodstream infections. You have 5 days for liquid culture, 10 minutes just for gram stain, then you have antibiotic sensitivity, and this takes anywhere from 3 to 7 days. In a patient with cirrhosis, if we use this to guide antibiotic therapy, it is often too late, because it takes 24 hours to 72 hours for those patients to slip into multi-system organ failure. So what happens if you incorrectly diagnose or incorrectly treat patients? The microbial therapy, if someone with cirrhosis comes in with septic shock, this is the percentage mortality on your left y-axis, and this is when the appropriate antibiotic is started. Not just any antibiotic, the antibiotic to which the organism is actually susceptible to. If it's done within 0 to 3 hours, it's still a high mortality. But if you look, it takes 6 hours for you to start an appropriate antibiotic. The mortality is almost 100%. So it's too late. What about inappropriate antibiotics? Means the antibiotics that you think that could cover this organism, but actually it does not cover it because it's a resistant bacteria or it's not a bacteria at all. 9.5 odds, which means almost a 10 times rate of mortality for these patients. So the consequences are very, very dire for these patients. So what are the clinical clues and the traditional methods? We know that usual signs of infections are absent. So you want to know if someone has altered mental status or hepatic encephalopathy, is the nice talk done by Dr. Dheeman before. It is infection unless proven otherwise. Acute kidney injury, which we know can be as subtle as a 0.3 milligram increase in creatinine. Asymptomatic could have silent SBP. And remember, the WBC count could be actually considered normal. So if someone goes with a WBC count of 3,000 and now it's jumped to 6,000, it's a doubling for that patient. But because of hypersplenism, this will not actually change anything in the electronic health record. It will not turn red, it will not turn H, but you have to figure out what that patient's usual WBC count was. So we also need to be mindful of patient groups at risk for drug-resistant infections. On the left-hand side, you can see resistant to third-generation cephalosporins in Europe has exploded. And on the right-hand side, we did the study in patients across the Veterans Hospital across the United States. These are more than 300 centers which take care of people who are veterans, who have multi-comorbid conditions, and we honed in on patients with primary SPP prophylaxis, which means these patients are on antibiotics with not without SBP before. And what we found that the rate of people who developed their first SBP episode, despite being on primary SBP prophylaxis, had a much worse outcome. There's a huge amount of antibiotic resistance. And as a consequence of this one paper, the VA hospital has kind of banned primary SBP prophylaxis across the system because there's a high rate of antibiotic resistance. So what do you mean? So you need people on SBP prophylaxis, people with higher MELD score, people with recently hospitalized patients, and people who are getting a nosocomial infection, and those in the ICU. These people have to be started on the broadest spectrum antibiotic possible while you're awaiting for the culture. Once the culture comes back, then you can narrow it back. Because if you waste time doing a narrow spectrum antibiotic right now, the chances are that this person will slip into acute and chronic liver failure, and it's hard to bring back. But you have to follow the culture and draw the culture before that. Otherwise, if you start giving broad spectrum antibiotics to everyone, it'll be a problem. What about fungal infections? There's a higher possibility of fungal infections. Most of them come from 10% of the patients have fungal infections, and that's pretty high. But what are the precipitating factors? People who have been exposed to antibiotics, including SBP prophylaxis, or those patients who are not responding to the initial dose of antibiotics could either have a resistant infection or a fungal infection. But people with ICU admission, clearly, if they're not responding within 24 to 48 hours of your antibiotics, have a low threshold of starting antifungal therapy in those patients because it's very hard for these cultures to come back. And this is important because this is in a non-cirrhotic population. The time to culture positivity indicates poor prognosis. Basically, you try it, and even despite all your logistic barriers, if the culture comes back very quickly, that patient is not going to do very well. So don't waste your time on waiting for the antibiotic sensitivity to come back. So give them the broadest spectrum antibiotic at that point. So we talked about the traditional therapies, the traditional methods. They take a long time. The clinical clues are very subtle, and then you have taken 3 to 7 days for those cultures to come back. So what are some other techniques that have been explored? So this is culture-based molecular pathology, non-culture-based molecular techniques. There's also a direct culture if you know what bug you're looking for. And then there's a workup again, which automatic things. The last two are a little difficult because you have to have an organism in mind. The middle ones are a little bit different because they take the entire genome and completely do the analysis from them. So one way of looking at this is doing the 16S RNA. If you look at the microbiome studies, these are actually things that have been done for generically expressing the microbiome of a particular fluid. But in specific areas, now these have been done in prosthetic joint infections. So you can see in prosthetic joint infections, it's very hard to get a culture because these patients are constantly on antibiotics, and those fluids are very hard to actually get to, even if the vascular system is intact. So what they ended up doing is they actually took an aspirate and ran them through the microbial pipeline, and they found that they were able to actually figure out who these bacteria were, and then were able to also figure out whether those bacteria had antibiotic resistance genes. This is obviously not something that we can do in every single person with cirrhosis, and right now it's really not ready for prime time. But in these patients, which are very hard to actually figure out, they were able to actually do this. There's another technique in the US. It's a commercial technique, a commercial company called Carius, K-A-R-I-U-S, and this comes with cell-free DNA analysis. You precipitate you take the blood, it sequences analysis and comes back the report. The report comes with bacteria, yeast, viruses, parasites, and archaea. Basically, the entire microbiome that is in the system, in the bloodstream, can actually be targeted. And I want you to focus on this. Look at these blood cultures. It's all the other stuff in this. Anything in this orange bar is the subject that was the microbiota that was responsible for the infection was identified using conventional microbiology. Of course, it took 3 to 7 days to come back. Look at this one, the black one. All of these actually were identified with this cell-free DNA. But this is extremely expensive. It takes $2,000 to $3,000 per sample. So it is obviously reserved for the most important cases in which you are suspecting a septic shock or something in these patients. The patient is a transplant candidate. But what it tells you right now, that the field is moving forward from traditional culture. We just have to iron out some kinks and of course make sure that this is not as expensive. And this has been done by a Chinese group here in patients with advanced acute decompensation and stable cirrhosis with severe sepsis. And they actually found that there was non-hepatitis virus in this. Now, whether this CMV prevalence was actually clinically significant or not, they were able to figure out that CMV was the cause of the decompensation in these patients and were able to treat this in patients. But reactivation is not really something that we think about in our patients with cirrhosis. But suffice it to say, the field is moving forward a little bit. But what are the challenges? It's very expensive. There could still be a high turnaround time, which kind of makes a mockery of why we need this. There's a contamination with host DNA. So that's why you have to actually make sure that the DNA that you're actually testing is the microbial DNA. There's an inability to distinguish, this is very important, between dead and live bacteria. So the bacterium that you may actually be figuring out may be dead a long time ago, and you don't need antibiotics. And you clearly need bioinformatics expertise. So you really need to figure out these things before we jump in, but things are moving forward a little bit. So how do you prevent infections? You want to focus on the immune dysfunction, altered microbiota, and most importantly, extraneous factors. So immune dysfunction is in the liver, systemic circulation, and the gut barrier. You clearly want to address the etiology of disease, reduce readmissions and admissions, and importantly, vaccinate your patients. Please vaccinate your patients. This seems very boring. You do not want to outsource it to the primary care physician. Most patients with cirrhosis, we end up becoming their primary care physician, and we have to actually make sure we advocate for preventative care for these patients as well. Pneumonia, influenza, COVID-19, whatever the latest version is, please make sure that your patients do it because they don't have enough reserve for this to actually move forward. What about altered microbiota? It's not just the microbiota itself, it's what they're producing. On the top part is the metabolites were able to predict who actually develops nosocomial infections. This was done as part of INASL. In the bottom, we were able to find out that it's not just the bacteria, but also their bacteriophages that were able to link with E. coli in patients who developed SBP prophylaxis associated infections and those who did not. So this is important to realize it's not just the bacteria itself, it's also the viruses in these patients. Here is the meat of the matter right now. What can we do right now to prevent infections? Because diagnosing them may be hard and treating them appropriately may even be harder. You want to use less antibiotics. Clearly this is a problem, including primary SBP prophylaxis. In our VA system and currently in our hospital, we do not use primary SBP prophylaxis in patients with low protein ascites. We use it temporarily for patients who come in with an upper GI bleeding, only for 5 days as is recommended, but primary SBP prophylaxis is not in our system. Non-antibiotic medications, as we are going to talk about in the next slide, are also critical. We want to change practitioner behavior as well as logistics. So what is practitioner behavior? So we did an analysis of patients in the ICU who had, during COVID and before COVID, during COVID and before COVID. During COVID, less visitors, everyone wore a mask, contact isolation, less. So what we found, despite a high melt sodium, high Q-SOFA and WBC count, and higher length of stay in the COVID era for patients who were COVID negative but had cirrhosis, there was less nosocomial infections and higher liver transplant. How do you explain that? It's us. We need to do less contact with the patient, and in a patient with cirrhosis, if you actually follow COVID criteria, those patients may actually have a better prognosis. So if you have a hematology consult, there's no need for the hematologist to come and see the patient. The hematologist can do it remotely and charge the patient if need be. If you have to see a patient, use a mask still, because these patients, as I told you, are immunosuppressed. And this report clearly says that despite all these things, these patients have a better outcome if they were treated in the COVID situation. So this may be an intriguing practitioner behavior we can take behind. Clearly, we want to reduce PPI. We already talked a little bit about statins, but in decompensated patients, things become a little challenging. The statins have a lot of impairment in the muscle, so you really don't want to start someone on this. Whether you want to withdraw this is something that we are not clear yet. Beta blockers can be important in patients with SBP, but clearly there are non-antibiotic ways to do this as well. This is very important. Again, in the Veterans Hospital, we are able to track who got a paracentesis within 24 hours. In patients with cirrhosis with ascites, it's shocking. less than 15% of them got the paracentesis within 1 day of admission. This is the guidelines. And what really was important, it's a U-shaped curve. The mortality was the lowest who actually got it within 24 hours. The mortality was the highest who got it after 24 hours. Granted, that includes nosocomial SBP, and even higher and a little bit intermediate in those who did not get a paracentesis at all. So this is practitioner behavior. You want to make sure that everyone with cirrhosis and ascites who gets admitted non-electively, even without signs of SBP, gets a TAP, at least a diagnostic TAP, because you may actually miss SBP in these patients. So in summary, we need to suspect infections early and have a rapid and flexible strategy. Current strategies to detect them need improvement. Non-culture-based strategies are being developed but are not ready for prime time yet. A high index of suspicion and adequate coverage for MDR and fungal infections, especially in those with prior antibiotics in ICU, are needed. Ensuring prompt diagnosis, up-to-date vaccinations, removal of unnecessary PPI and antibiotics, including primary SBP prophylaxis, and consideration for continued masking are needed. Thank you so much for your time.
Thank you, Dr. Bajaj, for your wonderful talk. Our next speaker is Dr. Shalimar. Please be seated here on the stage, Dr. Bajaj. The next speaker is ammonia and cirrhosis and ACLF, and this is Dr. Shalimar who's going to give the next talk. Dr. Shalimar?
For not making it in person.
He's not here.
I would like to thank Professor Ajay
he's
D'Souza, Professor S.P. Singh for the kind invitation. In the next 10 minutes or so, I'll take you through the data on the role of ammonia in cirrhosis and acute on chronic liver failure. I'll talk to you on the ammonia kinetics. I'll show the data available on role of ammonia in patients with cirrhosis, especially in the subgroups outpatients and critically ill and acute on chronic liver failure patients. I'll take you through the factors which affect the ammonia levels, which we need to keep in mind while interpreting these results, and briefly talk on the therapeutic targets which are available for reducing ammonia in these patients. Ammonia is produced in our intestine, and the predominant source of ammonia is the food. Along with this, the bacteria, which we know as the gut microbiome, plays an important role in the production of this ammonia. This ammonia, when produced, goes from the intestine to the systemic circulation and is taken up by the liver, where it is converted into urea in the urea cycle, and this is then excreted out from the kidneys in the urine. We know that in the presence of non-functioning hepatocytes, what we see in patients with liver failure, this ammonia utilization is reduced and there is an increase in the ammonia levels. There comes the role of other organs which are involved in the ammonia metabolism, the ammonia clearance. These include the brain and the muscle, where ammonia is converted by combining with glutamate to glutamine. And we know that in patients with cirrhosis, there is sarcopenia, thereby limiting the step of ammonia clearance. And this leads to a cascade of events in which the ammonia affects the other organs. So ammonia has toxic effects on multiple organs, especially the brain, where it causes cognitive dysfunction, and the clinical manifestation is as hepatic encephalopathy. There is astrocyte swelling, inflammation, and mitochondrial dysfunction. In the liver, elevated ammonia levels lead to hepatic cell, stellate cell activation, oxidative stress, apoptosis, clinically manifesting as inflammation in the liver and fibrosis. In the muscle, there is activation of myostatin and oxidative stress by these elevated ammonia levels, which in turn leads to sarcopenia. Apart from these effects, the ammonia levels also have an effect on the immune dysfunction. It leads to a reduction of phagocytosis and oxidative stress, thereby predisposing an individual with liver failure who's got hyperinsulinemia to more infections. and infections are commonly seen in patients with acute or chronic liver failure. The role of ammonia in ALF, that is acute liver failure, is well defined. Increased glutamate to glutamine, that is, glutamate combines with ammonia to form glutamine in the brain, leads to intracranial hypertension, astrocyte swelling, and brain edema. Ammonia has been shown to be of utility in predicting outcomes in patients with acute liver failure. Among acute liver failure patients, those who have elevated levels of ammonia have higher rates of cerebral edema, have higher grades of hepatic encephalopathy, that is grade 3 and grade 4 encephalopathy, and these patients also have higher prevalence of seizure. Coming to the role of ammonia in patients with cirrhosis, in the subgroup of patients who are outpatients, this study reported that patients who had higher levels of ammonia, which they defined as 1.4 times the upper limit of the normal. These patients, when categorized based on the high levels and low levels of ammonia, were seen to have distinct complications in the form of liver-related complications, which was defined as a composite of bacterial infection, acute varicose bleeding, overt hepatic encephalopathy, new onset or worsening of ascites, was seen more commonly among those patients who had higher ammonia levels compared to those who had lower ammonia levels. In addition, this study also reported that the overall survival probability among those patients who had higher levels of ammonia, the survival was lower compared to those who had lower levels of ammonia, thereby suggesting that ammonia estimation in outpatient can help predict the development of complications, specifically liver-related, and outcomes in stable patients with cirrhosis. Similar results were reported from another European center, which also evaluated clinically stable outpatients with advanced chronic liver disease. And when patients were categorized based on different quintiles of ammonia levels, those who had higher levels of ammonia had higher liver-related deaths and hepatic decompensation compared to those patients who had lower levels of ammonia, thereby again suggesting that ammonia estimation probably may have some role in predicting complications in cirrhosis patients at follow-up. The authors also developed a model for predicting overt HE in these stable patients with cirrhosis, which were seen on an outpatient department. And this model consisted of components such as sex, diabetes, albumin, creatinine, and ammonia levels. The authors validated their model in 2 external cohorts. We need more data on validation of this model before we can use it for clinical use in predicting OHE in outpatients with cirrhosis. This study from our center, which also included patients from the UK, that is Professor Jalan's group, we included patients who had acute decompensation and acute and chronic liver failure. When patients were categorized based on the different grades of hepatic encephalopathy, higher ammonia levels were seen among patients who had grade 3 and grade 4, that is advanced hepatic encephalopathy, compared to those who had grade 0 or grade 1 hepatic encephalopathy, thereby suggesting a possible correlation of ammonia levels with grades of hepatic encephalopathy. On analysis, we found that ammonia levels were an independent predictor of advanced hepatic encephalopathy after adjusting for other variables on multiple different multivariate models. In addition, ammonia was also found to be an independent predictor of survival on multivariate analysis. When we categorized these patients into different grades of hepatic encephalopathy, we found that patients divided on the basis of high and low ammonia values on a cutoff of 79.5 micromole per liter would help distinguish the outcomes in the various categories of hepatic encephalopathy, thereby suggesting a possible role of ammonia levels in predicting the outcomes in these patients. In addition, when we compare those who had higher ammonia values versus those who had lower ammonia values, patients with cirrhosis had higher organ failures among the group which had higher ammonia values compared to those who had lower ammonia values. There is, in addition, some data to suggest that possibly there is no role or no correlation of ammonia with the amount of lactulose consumption. This study published from the United States also highlighted that there was no difference in the HE resolution among the group of patients, among those who was ammonia levels were estimated, and among those in whom the ammonia levels were not estimated. In addition, they also showed that there was no difference in the rate of HE resolution among those who had higher ammonia levels compared to those who have normal ammonia levels. So there is contrasting data available in the literature on the role of ammonia in predicting the grades of hepatic encephalopathy and as the data which I have shown. So is there any role of serial estimation of ammonia in patients with cirrhosis and acute and chronic liver failure? In this study, we had included all patients with acute decompensation and acute and chronic liver failure and estimated their daily ammonia levels for 3 days. And we categorized these patients into 3 groups: those who had a persistent or an incidental hyperammonemia defined as elevated ammonia more than 79.5 on day 3, and those who didn't have ammonia levels more than 79 on day 1 but had more than 79.5 on day 3, and no hyperammonemia as those who had an ammonia less than 79.5 on both day 1 and day 3. What we showed over here was those patients who had persistent or incident hyperammonemia had poor outcome compared to those who did not have any hyperammonemia. And with the risk categories, we could divide patients into low risk and high risk, and thereby triaging patients at risk of poor survival. Similar results have been reported, and these studies from a multi-study from a multi-center cohort of Canada, Portugal, and US validated our results showing similar levels of ammonia levels being higher in higher grades of encephalopathy. Non-survivors had higher ammonia levels, and day 2 ammonia levels independently were associated with a higher mortality, and each rise of ammonia by 10 led to an odds ratio of 1.1 for the mortality. And similar results have also been reported from the ARC database, suggesting the potential role of ammonia in predicting the outcomes and as a predictor of hepatic encephalopathy. I've shown you convincing data on the role of ammonia, but then there are factors which influence the ammonia levels in patients. And this elegant study by Professor Jaswan Bajaj showed that among cirrhosis patients, the consumption of protein was associated with an increase in the ammonia levels by 12% and 18% at 1 hour and 2 hours. So we need to keep in mind, yes, there are multiple factors which affect the ammonia levels in patients. So apart from the factors which I showed, that's the liver failure and the diet, there are other factors including GI bleeding, presence of renal failure, sepsis, certain drugs, and total parenteral nutrition which affect the ammonia levels. So published data from heterogeneous cohorts is causing confusion to my mind in the role of ammonia as a predictor of outcome, and we need to keep in mind these values or these factors which can influence the ammonia values in your patient, and we need to be aware and we need to evaluate for other causes of ammonia elevation in such There are multiple targets which are available which can reduce the ammonia levels, including lactulose, antibiotics such as rifaximin, neomycin, metronidazole, sodium benzoate, LOLA, branched-chain amino acid, albumin-based dialysis, flex, bioartificial liver, probiotics, and a possible role of fecal microbiome transplantation. I'll take you through a few of them. This study showed that use of L-ornithine L-aspartate in patients with cirrhosis is associated with a significant reduction in ammonia levels. CRRT has been shown to reduce ammonia levels. Its data in patients with acute and chronic liver failure, still we need more data. Plasma exchange has some role in the management of patients with acute and chronic liver failure, and upcoming data would clarify its role. And Flex has been shown to reduce the ammonia levels in this elegant study by Clemmensen published in 2001. So, ladies and gentlemen, I would like to conclude here by stating that ammonia definitely has a prognostic value in patients with cirrhosis and acute and chronic liver failure, but we also need to keep in mind that ammonia values are affected by multiple factors, and these need to be kept in mind while interpreting a patient's ammonia value. A single value may not be does have a role, but then serial estimation definitely has been shown to be of utility in predicting the outcomes. Targeting measures include drugs, renal replacement therapy, and plasma exchange. Ammonia is one player in the ACLF syndrome. We still need more data on its role in patients with acute and chronic liver failure, and we need future well-designed studies on ammonia targeting and outcomes. Thank you.
Next, I would invite Dr. Ashish Kumar to give his talk on predicting HCC in cirrhotics. Dr. Kumar, please.
Good afternoon, ladies and gentlemen. Thank you, INASL, for giving me an opportunity to present here. So I would present about prediction of HCC in patients with cirrhosis. So in a normal liver, it's very rare that a person can get HCC. But if there is liver fibrosis, even though there is no cirrhosis, then the chances of HCC are slightly higher, although it will still be rarer. And once cirrhosis sets in, then it is common that person can develop HCC. That is why surveillance strategies have been formed. And if cirrhosis with HCC is already there, and with we have done treatment for HCC, then recurrence of HCC is even more common. So having this framework in mind, let us explore further how various modifiers can further enhance the risk or reduce the risk of HCC in the cirrhosis patients. Okay. So risk factors of HCC are well known, and we in 2014 in our first guideline on HCC, we published that chronic hepatitis B, chronic hepatitis C, alcohol consumption, aflatoxin, all these are important risk factors, and the disease modifiers like diabetes mellitus, NFLD, smoking, and tobacco use are also contribute to HCC. Now let us look at the impact of etiology on this framework. How does it affect the outcome? So this study, which was done way back in 2004, gave various 5-year cumulative risk of HCC based on etiology. So hemochromatosis had the highest risk of HCC, 21% in 5 years. HCV cirrhosis, 17%, B cirrhosis, 15%, NASH cirrhosis, 4%, and alcoholic cirrhosis, 3%. So let us look at the viral etiology first. So mechanism of HCC in HBV cirrhosis are many. There is liver inflammation, then liver gets cirrhotic, and then there is disrupted growth, and then there is role of somatic mutations like TERT, and which are enhanced by this viral genome. And then there's HBV integration into the host genome. And then there are contributing mechanisms. So chronic inflammation, HBV integration, signaling pathways, immune evasion is also there. Then somatic mutations and HBV X proteins and HBV genome mutations all contribute to HCC in a patient who already has chronic liver disease due to HBV. And we showed in cohort from Gangaram that hepatitis B virus infection can cause HCC even in less advanced cirrhosis. So we showed that even patients who are younger, patients who had less advanced cirrhosis, less advanced CTP score, and even in absence of cirrhosis, HBV was able to cause cirrhosis, HCC. And according to the global burden of disease data, which was published, which has been published many times, and this is the latest one in 2019, it shows that the HBV is the most common cause of HCC because of two reasons: because it is a very strong cause of leading to HCC, and also we have a very large HBV pool, especially in South Asia and China and all these countries. And so because HBV can cause HCC in so many ways, there are various HCC risk calculators which take into account like HBV status, viral load, genotype, age and hepatic inflammation, family history, gender. So many risk calculators are there. For example, REACH B score, PAGE B, CU HCC scores. Although these are there, but these are not very well used in clinical practice. Now talking about HCV, now we encounter mainly patients who have, with the help of direct acting antiviral agents, we have cured their HCC. So what is their residual risk of HCC? So according to this study, which was published just a few days back on 20th July, the 5-year cumulative risk of HCC in patients of hepatitis C who have been cured with oral direct-acting antivirals, the 5-year cumulative risk is now 6%. And the variables which independently are associated with HCC risk are advanced fibrosis, higher AFP level after direct-acting antivirals, higher LB grade, and higher BMI, which contributes to HCC. So taking all these viral factors, we had in the next edition of HCC guidelines in 2019, we had said that patients who have cirrhosis due to HCV or HBV have the highest rate of developing HCC as compared to those, as compared with chronic hepatitis patients or as compared to cirrhosis due to other etiologies. And in non-cirrhotic patients also, there is some increased risk of HCC in patients with HBV and HCV. And for hepatitis B, if there's HBE antigen positivity, that carries a higher risk. And in non-cirrhotic HCV patient, if there's advanced fibrosis, or that leads to HCC. And if the hepatitis B or C has got concomitant other viral infection, like HBV and HCV co-infection or HIV co-infection, or if there's concomitant alcohol use, obesity, diabetes, aflatoxin exposure, then the risk of HCC is higher. And in Indian HBV patients, HBV genotype D, higher HBV DNA levels were associated with higher incidence of HCC, and in HCV genotype 4. And after SVR, then there's no difference in occurrence except when there is increased risk of fibrosis. Now let us look at risk of HCC in NFLD patients. In a recently published systematic review, it was found that in patients of NAFLD without cirrhosis, the risk of HCC is 261% higher than as compared to other etiologies in non-cirrhotic patients. So that is why we are seeing a lot of patients who come with HCC in a background of NFLD who do not even have cirrhosis. So NASH is the leading cause of non-cirrhotic HCC nowadays. So in patient with NAFLD, how does risk of HCC occur? So if there is NASH plus cirrhosis, then the risk of HCC would be higher. If there's concomitant diabetes, there's older age, male, if these patients have metabolic syndrome, obesity, and also certain genetic modifiers like PNPLA3. HCC surveillance, there are a lot of barriers. In this study published by Dr. Amit Singhal and the group, just published 3 days ago, they said that there are many challenges and barriers to HCC surveillance in patients with NAFLD because there is poor disease awareness, and more than 1/3 of patients do not have cirrhosis, so they are not under any surveillance program. And then there's limited visualization by ultrasound, so ultrasound is not able to pick up these patients. And also the at-risk population is huge. So there's 1/3 of population is having this fatty liver disease, so it's a huge population. So, the risk of HCC also increases. The recently published AGA clinical practice guidelines have even mentioned that if non-invasive testing in NAFLD patients suggest advanced liver fibrosis by the way of FIB4 being more than 2.67 or FibroScan more than 16, then these patients should be subjected to similar HCC surveillance as cirrhosis. Now let us look at HCC risk in alcoholic liver disease patients. In this meta-analysis, which published few days ago, of 18 studies of more than 1 lakh patients, the cumulative HCC risk in alcoholic liver cirrhosis patient at 1 year is 1%, and at 5 years it was 3%, at 10 years and 9%. And the risk was increased by concomitant smoking, diabetes, hepatic decompensation, and also variceal bleeding. Now let us look at diabetes. So we have seen that diabetes is coming at so many, it is enhancing the HCC risk at so many places. So type 2 diabetes, hepatic decompensation, and HCC. This elegant study published just few years ago, it showed that a person having type 2 diabetes, the 5-year cumulative risk, will be having 3 times more higher chance of developing HCC as compared to those patients who do not have diabetes. And the duration of the diabetes is also important. So those patients having diabetes of more than 10 years are at much higher risk as compared to those having diabetes of less than 10 years or less than 5 years. And also what treatment the person is receiving. If the diabetic patient is receiving biogonides, then the risk of HCC is lesser. So metformin is protective. Another study which looked at 85,000 patients where effect of diabetes medicine and glycemic control was looked at, and it was found that metformin is protective, and if the person has got good glycemic control, then these patients have lesser chance of diabetes as against patient taking other drugs like insulin or sulfonylureas. So what is the impact of prior HCC? That means this group of patients who have been treated for HCC now cured, and what is the risk? And so HCC recurrence after a curative therapy, the recurrence rate after liver transplantation overall is about 13%. After resection, it is 5-year risk is very high, up to 70%, and after ablation it goes even higher, up to 85%. So what are the predictors of recurrence? The underlying presence of underlying cirrhosis, the morphology of tumor, if the initial HCC was bigger size, the large number of tumor nodules and extent was large, then there's a higher chance of recurrence even with curative therapy. Then biology, there's increased role of alpha-fetoprotein, PIVKA. If these are higher, then there are a higher chance of recurrence later. And the etiology of HCC, HBV has a higher chance of recurrence. So I would, on this background, on this framework, I will give you just 4 take-home points on increased risk of HCC. So in patients of cirrhosis, HBV has definitely increased risk of HCC, and especially if HBV is there along with co-infections with HIV or HCV. In NASH patients, even without cirrhosis, advanced fibrosis can lead to increased risk of HCC. Diabetes puts an added risk to both the cirrhotics as well as non-cirrhotics for development of HCC, but metformin may have some protective role, and prior HCC has got, after curative treatment, would have the highest risk of HCC. Thank you for your patience here.
Thank you, Ashish, for that. We can take up some questions from the audience. I think we can direct the questions first to Dr. Jasmohan Bajaj. How early a patient comes with leukocytosis, high CRP, and we are not certain whether it is SIRS response or is it sepsis. So what should be the follow-up of such patients?
It's a very important question. There's always a diagnostic challenge in these patients. So we have to ask ourselves, what will happen if we miss an infection in this person? What bad things could happen? And track it back from there. Imagine the worst case scenario, which we usually do. The challenge is to educate the people who first are in touch with that patient, who are not the consultants, the ER physicians or the house staff in the hospital at night. So the focus there is to make sure that adequate cultures are drawn and then start them on broad spectrum antibiotics. And someone needs to follow those cultures. It's amazing how many times you drop the ball and not follow that culture to narrow that again and follow that patient. So my feeling is to err on the side that this is infection, and within 2 or 3 days it will be very clear if the patient is responding, not responding, or there's an alternative cause for that leukocytosis or CRP, etc. in that patient.
And always start them on a higher antibiotic and then...
Yes, provided that you've drawn the cultures first.
Cultures first.
So that you have something in the bank to actually refer back to.
Yes, doctor.
Question to Dr. Ashish. Since we know now that various risks of having HCC in different categories of spectrum of liver disease, do you have any guidelines for screening them? The screening tools that we clinically use, alpha-fetoprotein and ultrasound, are very, very low sensitivity. Do you have any other strategies to pick them in right time?
So there are many strategies that are being looked at, like abbreviated MRI, especially in patients who have higher risk of HCC. But most of these strategies like abbreviated MRIs or even looking at various other markers like PIVCA and AFPL3, then GALED score and GALED US, these are being worked out, but when we decide about surveillance, we are thinking about the entire population. So it has to be cost effective, and we have to see if the cost of surveillance goes too high. And once the surveillance detects, suspects these patients, then we have to further subject these patients to further enhanced testing by triple phase CT. So we have to balance both the things. So it has to be cost effective. That is number one thing.
As of now, there is no specific guidelines.
No specific guidelines. The only guidelines are there if the patient is having cirrhosis, then you have to do every 6 months ultrasound plus AFP. And some guidelines like AGA, I mentioned that even patients who have NAFLD with advanced fibrosis, by non-invasive testing, they are subjecting these patients also to similars.
Dr. Ashish, the same question, 6 monthly. I've hardly ever picked up an HCC during this particular follow-up of 6 months. I don't know how, we do have a strict follow-up. I don't know how many in the audience have really picked up the 6-month protocol and picked up the HCC in that. Most of them come to us in advanced stage.
So the reason why most of these come in the advanced stage, because the patients which we are following regularly at 6 months are not developing so much, not developing HCC, but those who, there's a huge pool of patients who are not even subjected to even simple ultrasound, or like huge pool of NAFLD patients with advanced fibrosis, diabetic patients. So they first time present with HCC. So that is how actually this surveillance strategies are not delivering.
Dr. Kumar, we have more than 100.
So I wanted to add to this. So it's a good thing that most of these things are very indolent. Very rarely that you find somewhere in between 6 months, and that's why the natural history studies that actually made this, actually some people say 6 months to 12 months as well in between. So it's really nice for us to actually, it's a reassuring thing that there's no one develops this. So you remember that analogy of that plane who got shot with all these places and still returned home? So it means that the essential parts are still being covered, whereas the unessential ones in which the HCC, the very rare occurrence of HCC that happens in between in advanced stage in these follow-up. So it actually adds to the validation of the strategy that most people do not develop it in 6 months because you would rather be safe than sorry in these patients.
So I was just going to add to this that we have more than 100 million, latest study of 2021, we have 100 million diabetics in our country now in India. And more than 50% are going to be NAFLD and NASH. So we are looking at 50 million, which is more than 5 crores. So in them, if we don't start, surveillance, because we have 4%, but then just look at the numbers in our country, it's going to be huge. So we have to start surveillance on those patients also.
So this latest ICMR data, which Dr.
Ranjana recently.
So this is a huge population. So the problem is that even liver fibrosis is not being screened
So
in
we
them.
have to
so
educate
HCC is a long way to go.
endocrine doctors.
So first we have to educate the endocrine and the general physicians who are managing these patients that at least start doing fibroscan in these patients and to detect more cirrhosis. So they are more focused on the MACE and the cardiovascular outcome. And so liver outcome have to be screened in these patients.
So my question is to Dr. Bajaj. How do you use the rapid diagnostic tests like D-glucan and galactomannan and the biofire assays for your early diagnosis and treating the patients?
We very rarely end up using it because there's a lot of, by the time you end up using it, you already have such a high suspicion for fungal infection that the more cost-effective way is to just start the fungal therapy and see if the patient gets better. Because if you put it in every single patient who comes to the ICU, there'll be a lot of hit and miss in those patients. I would still start at least 24 to 48 hours of very strong, broad-spectrum antimicrobial therapy for bacteria in those patients. Now, biofire is one of the same things that I talked about.
Yes.
That also is very expensive.
Yes.
We use it very sparingly.
And multiple tissues.
I'm sorry?
Multiple tissues to be considered, like the sputum, the blood. The
I know,
urine.
and that adds up because
Yes.
they charge you per sample. They don't charge you per patient.
Right.
So you have to use it very sparingly, knowing that there's going to be a lot of hit and miss. These patients, that the last study that I presented to you from China, there were 8 patients out of thousands that there was a true diagnostic conundrum that they really could not figure out after multiple times, and then the CMV came in that. So in most cases in our patients, tragically, it will be a multi-drug resistant bacteria, which will take a long time.
What
And if
we are seeing is we use the chest CT initially to screen, like we are more concerned about the invasive aspergillosis.
Yes.
The echinocandins we are giving as per the guidelines for the high melders and the ones on who have high risk factors. But a lot of times the chest CT shows all findings of fluid overload. And we are not really able to interpret whether there is an underlying infection.
But in our, at least in the Western population, we don't have that much of aspergillosis anymore. It's usually a lot more candida. And even what we think would be like quote unquote like candida esophagitis or whatever, those also are markers of bad prognosis. So that's why our thing is much more echinocandin friendly, unless of course it's Torulopsis or glabrata, etc. And nowadays we have this Candida auris, which is just horrendous and has all our infectious disease persons very scared.
So we are not really using the rapid test.
No, we are not really because of the very high, very low sensitivity and specificity.
Right. Okay. Thank you.
Right, next, please. Yeah, Doctor.
So, Dr. Bajaj, we understand from our lecture today that no prophylaxis for SBP, despite the fact that the history of SBP in a patient, previous history.
Primary prophylaxis.
Yes.
Secondary has clear benefits. So I said primary prophylaxis, people with low protein ascites, etc. In our system across the VA, they've said that because the baseline resistant to ciprofloxacin, part 1, we do not have norfloxacin in the United States. We only have ciprofloxacin. And then very few people use Bactrim or trimethoprim sulfamethoxazole in the US for primary prophylaxis. So in patients with primary prophylaxis, the ciprofloxacin resistance in the VA across the veteran system is as high as 50%. So even if it was effective at some point, right now it is not. So they made the pragmatic decision to discourage it in those patients. So now comes the problem of if someone is already on primary prophylaxis, do you stop it or do you just not start? So all my colleagues who are in the VA system leadership, do not want to stop. They will just encourage the patient, give them the risk benefit, and if the patient stops, that's fine, because no one wants to be responsible to stop things. We want to be responsible to not start things. That's just human tendency. So clearly, secondary SBP prophylaxis with prior SBP is still very effective. Please use it. And primary SBP prophylaxis in the setting of an upper GI bleed for limited time is also very effective. Please use it. In our population, we did not find that the risk benefit for primary SBP prophylaxis in the setting outside of a GI bleed is important. It is more towards the risk than to the benefit.
So, in your opinion, a patient with cirrhosis of liver, with fever, suspicion of infection somewhere in the body without localization, what is the antibiotic therapy you are proposing in US? What is the group of the antibiotics you are using?
So it's all location, location, location. You need to find out what the patients with cirrhosis and immunosuppression in your hospital typically grow, and then actually make the decision. Even in the reviews that have been written, it's all a generic thing that we think in our population this will happen, but please go back to your hospital and what your
patient has come afresh to the hospital with a history of infection and a cirrhotic background.
So the assumption
that is
is
the time when we have to give the antibiotic. What is the group